Okay. As Dr. Manriquez said, I'm Tara Sundem. I'm the co-founder of Hushabye Nursery and a neonatal nurse practitioner, and I'm going to try to give you an overview of neonatal abstinence syndrome in a very short time, but there's lots more to share. So, our objectives to talk about what substances cause neonatal abstinence syndrome, what the presentation looks like, and different treatments. I have no conflicts of interest, and just to let you know that my views are my views and not necessarily under this grant. This is unfortunately what we're seeing every day in our neonatal intensive care units. Since June 15th of 2016, the state of Arizona has been tracking the cases that are reported of neonatal abstinence syndrome. We've had over 1,642 cases in Arizona alone that have been proven NAS cases. In the United States, we know right now that every 15 minutes a baby is born with neonatal abstinence syndrome. This number is probably way low. Very few states do mandatory drug screens, so we're definitely missing a lot of those mamas unless they look like they have substance use disorder, opiate use disorder, or they actually admit to it. Are the only times in the state of Arizona that we are testing. We do not do mandatory drug screens on all pregnant women. The costs are astronomical. In 2017, I believe it was, 79% of the cases here in Arizona were covered by Medicaid. So it's costly, very, very costly, especially when the hospitalizations can be on average 3 weeks. We're getting better with that, but they're high. So what is neonatal abstinence syndrome? It is the condition that happens when the baby's been exposed to an opiate for the most part. When the baby's born, we cut the umbilical cord, baby's not getting that substance anymore, and baby goes through withdrawals just as an adult would. Just wanted to address neonatal opioid withdrawal syndrome and NAS. You're going to hear more and more about NOWS, but the term is used interchangeably. Really, NOWS is specifically the opioid withdrawal syndrome, nothing else. I would say for the most part, our babies are NAS because very rarely are they just exposed to one substance. But those moms that have been stable on MAT for a long time, those would be really what you would call NOWS. So our causes are your painkillers, are your most common causes of neonatal abstinence syndrome. Your SSRIs and your benzodiazepines definitely cause withdrawal, but the American Academy of Pediatrics does not say that we need to follow those babies for a longer time in the hospital. So what we're seeing are the initial withdrawal symptoms from an opiate. I just wanted to point out Kratom there. Kratom's a new herbal supplement that we're seeing that can be purchased in the smoke shops, is what I'm being told. There's one documented case study of a mom that reported that she needed her tea. Her baby was definitely presenting as if withdrawing, but all the drug screens were negative. They found out what mom was drinking, what she reported that she needed her tea, and it ended up being Kratom. I know that in the East Valley, after this was reported, we had another mama present, and it was the same thing. She was drinking her tea, and the baby definitely was withdrawing. But that was like on day 3 of us going, oh my gosh, what did this mom expose this baby to? And we found that out. She had no idea. Substances that may cause NAS are these others. I would say for the most part, nicotine. You're going to see babies really withdraw and withdraw very quickly. So if a baby comes out and is shaky from the get-go, of course you think hypoglycemia, you know, that is your initial rule out. But if the mom has been in labor for 24, 36 hours and she has not smoked or she hasn't vaped, more than likely you're looking at a combination of nicotine, and it could be the opiate. But always just remember that, take that into consideration. Factors that increase NAS: the larger, the bigger the baby. It's thought that the opiate is stored in the bone and the fat. That's a thought. We don't know for sure, but it sure is more prevalent in the bigger babies. Could it be the fact that the bigger babies are the more term and they have a more advanced neurological system? Absolutely. We know the polysubstance babies, at least in my experience, have the hardest time. And we do think that there is a genetic component. Things that decrease NAS: number one, biological parent and breastfeeding. Your withdrawal symptoms: I had one mama tell me that withdrawal was like having the worst flu and migraine times 100. I have to say, when it was dumbed down to me in that aspect, that's exactly what we see with babies. Okay, we don't cry that high-pitched cry, but when we have the flu, we're miserable. I don't know that we sneeze 3 times in a row, which is one of those withdrawal symptoms, but definitely that irritability, the vomiting, diarrhea, inability to sleep, breathing fast. You do all of those. This is what's going on in the body that explains why they're showing these signs. You have that increase of acetylcholine, the decrease in the dopamine, just so for your knowledge. The effects of prenatal substance use, I added this slide. You guys can look at it, but just so you know, prematurity can be a factor with opiates. I would say that we see that more on the untreated mom with opiate use disorder, so not necessarily the ones that are in MAT and doing well in their recovery. Low birth weight, I'm seeing in my, I'm sorry, that is my dog coughing. I'm seeing in my mamas, their babies are on the smaller side. They're not SGA, but they are definitely on the lower side. Later on, neurobehavioral symptoms, and child abuse and neglect with all substances. How do we manage babies? Number one, we should try the non-pharmacologic first. And I do think we're getting better in our neonatal intensive care units and in our overall care for these babies. But number one, and I cannot stress it enough, the biological parent, even if they come in high, having them there is doing something that you and I as a non-biological person can do. If a mom comes in and she's definitely under the influence, I encourage her to stay. I encourage her to just put her hand on the baby. Of course, I'm not going to let her hold. These families, if you're straightforward with them and tell them that it sure seems like maybe you're under the influence, they're not, very rarely are they going to deny it, at least in my experience, as long as it's in a non-judgmental manner. Just saying that, you know, we want you to be here, but right now it doesn't seem like it's safe enough for us to let you hold your baby. And then providing the environment that you and I need when we are withdrawing, or that we need when we have the flu. So we turn down the lights, we decrease the stimulation, shut off your computers, get rid of that white light. And then there's different techniques, and I can share a video of wrapping the baby and putting them in that fetal position, making sure that they have their hands to their face, putting their knees to their chest. Babies don't understand that you get them in that fetal position, and that's going to actually help their tummy aches. Letting them have a pacifier. Every mama that has been using or been prescribed an opiate, their baby needs to have a pacifier, and they just need to understand that that is the one way their baby can self-soothe. Making a shushing noise can help. Deep yoga breaths, for some reason, definitely work. They definitely decrease moms and the caregivers' stress, but babies respond to it. Doing a squatting versus the pat, pat, pat that we usually do for a baby, they respond. Really explaining to the families that there is that third-hand smoke. Babies respond, or it can have an impact on their little ones. So asking them to smoke outside, washing their hands, changing their clothes before they hold their babies. If we say it in a nice manner and just give the data, I have moms and dads do that. They'll make sure that they change their clothes or put a gown on, and then warm compresses to their tummies. Every mama tells me that when they're withdrawing, they get sick, and it's vomiting and diarrhea. Every baby that I have had deliver since the beginning of this year, we've had now 37, one was born last night, but every mom reports diarrhea and irritability and gas. So really, if we can keep that in mind, small frequent feedings. When you guys have the flu, you don't go eat a turkey dinner. So not being on that schedule of every 3 hours that we are in the NICU. If they want to eat an ounce every hour, hour and a half, let them do that. That small frequent amount is best. Breastfeeding is highly encouraged. There's been more studies on breastfeeding and medication-assisted treatment. So moms that are on methadone and buprenorphine, and it is safe. It does not matter the dose. Less than 1% of whatever mom's dose is goes through the breast milk. Everyone says, and I was one of those caregivers that said, well, of course, baby does better because they're getting some of mom's dose. Well, it's less than 1%. We pay a lot of money for donor breast milk for our preemies, our babies that weigh less than 500 grams, because we know breast milk's best. It's easier to digest, and we know that babies do better. There are studies now showing that that opiate actually changes the biome of the GI system. And so if we can at all possible have these moms breastfeed, because it does work. They can also, that bonding and that attachment is something that you don't get with bottle feeding. If we're feeding formula or breast milk, making sure that we warm it, feeding babies before we do a diaper change, don't let them spiral out of control. We are having a lot more success with Similac Total Comfort, or that gentle ease. Simethicone you can try. I don't know that I'm really a firm believer that it works, but if someone wants me to do it, sure, you can use it. And then the warm compresses. The assessment tools, all babies that are exposed to an opiate, the American Academy of Pediatrics says that they should be monitored minimum for 5 to 7 days in the hospital, minimum. I would love to say that this is being done, but it's not. There's different assessment tools, and I can't say that either of them or any of them, there's multiple ones, but the two that are being used most right now are the Eat, Sleep, and Console and the Modified Finnegan. Eat, Sleep, and Console is easy. Can they eat an ounce? Can they sleep for an hour? And can they be consoled within 20 minutes? Easy. Modified Finnegan scoring system, more difficult, but more and hard to have that inter-rater reliability and validity. Just because I believe, in my experience, we're not taught how to do the Modified Finnegan scoring system the appropriate way. We're also not taught, or we don't have a consistent caregiver when doing this. When I went to work in the neonatal intensive care unit, my ideal patient was not the baby that was going to cry 24/7. So if you're not, this is not your clientele, working with these babies and making it that you're biased doesn't make the score be high, and I'm trying to say this politically correct, is difficult. So we need to we need to improve on our assessment tools, I guess is what I'm saying, and stress again 5 to 7 days. Our pharmacological treatment here in Arizona, for the most part, we start with morphine. There's some states that are doing methadone. It has a longer half-life. Buprenorphine is being studied now. Those studies are new. Clonidine is probably now most everyone's second line of defense. So you're doing the morphine, you get up to more than 1 milligram per kilo per dose, and then you add on that clonidine. I will tell you that in my experience, I've looked for studies, babies that are exposed to multiple substances, if you're having a difficult time, so they're exposed to heroin, methamphetamines, and I don't know, Xanax. My experience, babies do better with that second drug being phenobarbital. Yes, you end up sending them home on phenobarbital. That's not one of those drugs that a mom is going to want to use. I would try it. If you're stuck, you've done morphine and you clonidine, you still can't wean on the baby. I would try the phenobarbital and get rid of the clonidine. Again, my experience. Consequences of neonatal abstinence syndrome later on in life: failure to thrive, feeding issues, reflux, oral aversion. We have babies that do wonderful, and I'm finding as I'm keeping track of my mamas later on, at about 9 months, they are starting to have that oral aversion. I had one mom come to me and tell me that her baby was now just attention seeking. And every time baby was eating, she would eat and then she put her fingers down her throat and throw up. And I was like, oh my gosh, I've never heard of that. And after talking with speech, they're like, something hurts there. Ended up doing a GI workup, and she had horrible ulcerations of her esophagus. So yeah, it hurt. Again, I think it goes back to that biome must be interrupted, and we're seeing it more and more. Neurodevelopmental deficits are definitely there. These are these kids that go to daycare and get kicked out of daycare. What if families were more open to sharing their history and their journey and not being afraid of being stigmatized and being judged? That maybe they go into kindergarten and tell the teacher that, yeah, my baby is substance exposed, that maybe this 30 kid classroom is not the appropriate environment. Moms say that sensory processing disorder is an issue throughout. I just wonder if we put them in that 10 kid classroom, if they do better. More and more, we're seeing babies later on having eye issues. That's not an automatic referral that you need to make, but just watch that wandering eye. I had a mom that had her second baby. She brought her to group the other day, and her first baby was 2. And he would look at me, and all of a sudden I would go to the side, and I'm like, she's like, he's doing great. Everything's fabulous. And I'm like, oh. So we got him referred. But she's pregnant with her second baby, and well, we're getting there. So opioid use disorder. I know that we've talked about this in previous presentations, but I cannot stress enough to really care for these babies. We need to care for the entire family system, and to really understand as caregivers that it's a brain disease. It's not a moral failure. No one, when they're 4 years old, says that I want to grow up and lose everyone that is important to me, not have a job, and be judged. No one does that. Some of us, unfortunately, have a predisposition to it. Some of us were given a prescription, and after that prescription was used up, we had an issue. Many of us do not go and get treatment because they're afraid to be judged, they're embarrassed, they're ashamed. So really understanding that it is a brain disease and not a moral failure. Why do moms not just stop? When they find out they're pregnant, why don't they just stop? I used to say this. I didn't understand that there was an increase in miscarriage. I didn't understand that if you go cold turkey, even if you're not pregnant, there's one study that shows that if you go to a 24-hour detox, 95 people out of 100 are going to relapse. If you go to a 28-day program, you're doing behavioral health services, you're figuring out what got you to where you're at, 80 people out of 100 are going to relapse. If you go on MAT alone, this study found that 45 to 75 people out of 100 are successful in their recovery on MAT alone. So only going to the methadone clinic or being prescribed buprenorphine or naloxone, they're actually showing that they're being successful. This study showed that if they added behavioral health services on top of that MAT, 95 people out of 100 were in recovery, in doing well. To add to that, when you go cold turkey, so say you're the 95 or the 80% of people that relapse, the next time that you use, you're 16 times more likely to overdose. So if we have a mom go cold turkey, we may not have a mom or a baby due to miscarriage or overdose. And it's definitely not recommended by ACOG. Methadone versus buprenorphine with pregnancy. There's studies that show that buprenorphine has a decreased length of stay and decreased need for pharmacological therapy. I question, and again, this is my experience, babies that are methadone are the babies that you saw in that video. They scream, they can't sleep, they let everyone know that they don't feel good. And I think of with the flu, when I have the flu in my household, everyone in the family knows that I'm sick because I let everyone know. When my son has the flu, he's quiet. He's in his bedroom. He's just like, leave me alone. I don't feel good. I truly think that babies that are exposed to buprenorphine or Subutex or Suboxone withdraw differently than methadone babies. They just sit there and kind of silently suffer. I call them silent sufferers. They have the scowl. They just want to be left alone. They still breathe fast. They have that mottling of the skin and the vomiting and the diarrhea. I just wonder if we're just looking and assessing, saying that they're not withdrawing and maybe underestimating what they're going through. Again, my opinion. And many mamas are being questioned or being asked, do you want to switch from methadone or to buprenorphine because of these studies? In the behavioral health land, it's discouraged. The risk for precipitated withdrawal, so as you're having to withdraw down to the appropriate dose of methadone to get to be able to switch over to the buprenorphine, there's, that, could we miscarry? Can it be done? Absolutely. And is it done safely? It has been done. When I see it, they're doing it in the hospital and watching very closely. But there's also that risk of return to use while tapering down. Medication-assisted treatment. Dose is not directly correlated with severity of NAS. Can't stress this enough. So when a mom comes in and says she's on 210 milligrams of methadone, I used to say, oh my gosh, that baby's going to withdraw. I will tell you, I've seen some babies, 100% of the babies that I'm caring for withdraw to a point. So I would say they all have neonatal abstinence syndrome, even though studies say 50%. But if you really look at what NAS and the diagnosis, or the diagnosis and the definition is, do they show signs and symptoms of withdrawal? Every baby, my 37 babies that have been born since January, have all had diarrhea, vomiting, and tremors, every one of them. Now, have all of them been diagnosed with NAS? No. But dose is not dependent. So a mom that's on 30 milligrams versus 210, I bet a baby that's on 30 milligrams thinks he's literally going to die. Baby that was exposed to 210 milligrams, we got by with just doing therapeutic techniques. Breastfeeding is encouraged, cannot stress that enough. And maternal hepatitis C, moms can breastfeed unless they're bleeding. So unless their nipples are cracked and bleeding, they absolutely can breastfeed. Recommended follow-up, a pediatrician, and I can't stress enough again, the trauma-informed approach. And what that truly means is we don't know anyone's journey and what they've been through. We don't even know what they've been through to be able to get to the hospital or to our support groups that day. So really taking into account that. Trying to get them a pediatrician that is methadone or MAT friendly, home visiting, getting them involved, home health, getting them involved. Most of these families have very few supports, very, very few. It's not uncommon for a mom to be going home by herself and really making sure that she has follow-up. And then the other recommendations as far as developmental pediatrician or neonatology follow-up. And then our NAS parent support groups. I wish we had more. We do offer for a week now here in the Phoenix area, but we could always use more. What if we started prenatally? Hushabye Nursery is doing that, and I will tell you that we are having fabulous outcomes by meeting them prenatally in a non-judgmental, trauma-informed approach, connecting them with MAT-friendly caregivers, so obstetrician, perinatologists. These families don't realize that they have a choice. They don't realize that, you know, they go to their obstetrician and their obstetrician doesn't treat them well, or they go and the staff don't treat them well. They have a choice, and helping them realize that, you know what, you do have a choice in that. So connecting them with those appropriate providers, because if they're not treated well, they're not going to go back, which means we're not going to have good prenatal care, which our outcomes are going to be not as good. If we had birthing classes that were opiate use disorder or substance use disorder specific would be fabulous. I don't know of those yet. Helping them understand that no matter what, DCS is going to be involved, getting home visiting on board. They're amazing what they do, and my families love their home visitors. Identifying their safety monitors for DCS, making sure that they do know the signs and symptoms of withdrawal, teaching them what they can do. I'm having moms that are going to the hospital beyond empowered and knowing what to do, and they're teaching the nurses. They're helping score their babies. It's amazing. Encouraging them to breastfeed, but also telling them that, you know what, THC is not just a benign factor, that they really need to cut that out if they at all can. Many of my moms say that they're using it for nausea, and I know that we talked about this in the last presentation. There's other things to do for nausea. So really giving them the data on it, that it isn't as benign as what the community says. And making sure that they are of their HIV and hepatitis C status and that they've been counseling. There's nothing worse than when I'm admitting a baby in the NICU and I see that we don't have an HIV or hepatitis C status. I have to go, have mom go and get that testing, and then she's already feeling bad and her baby, she ends up being positive, and then I have to do that counseling and say what our treatment's going to be for her baby later on. It's just should be done prenatally. Here's a bunch of resources for you, and then my many references. And that is it.